I'm going to just give you a brief overview of anti-angiogenic therapy. Actually, Myron Schuchman sort of took away a little bit of my thunder, but what I want to leave you with is a couple of practical applications for various patients that you may run into that don't seem to have much in the way of alternatives. I just will briefly show you what's involved in angiogenesis. There's actually 4 components. The first component is the bone marrow. And actually, the bone marrow cells, monocytes and macrophages in particular, play a role in the angiogenesis mechanisms of lymphoma. Most of the hemopoietic cells are responsive to VEGFR receptor 1, whereas VEGFR receptor 2 usually is the receptor seen on the progenitor endothelial cells. As it turns out, tumor cells down here that says R1, R2 very quickly have both receptors for R1 and R2, and the tumor cells not only give off VEGF, but VEGF-A, but VEGF-A comes around and hits the R1 and R2 receptors on the lymphoma cells, so you have an autocrine and a paracrine mechanism. The stromal cells give off what is SDF1, which is also known as CXCL12. You heard me talking briefly about when we were talking about the TKI inhibitors, when we were talking about Bruton's tyrosine kinase, and I asked the question, why is it that these cells get released? And the response to me was that the stromal cells get inhibited, giving off this particular cytokine called CXCL12 and CXCL11. These cytokines give off these cytokines attract both the endothelial cells, the precursors to endothelial cells, as well as normal hemopoietic cells, particularly the macrophages, and the monocytes, which contribute to the growth of angiogenesis. These precursor cells that you see will help the growth of the vessels in the tumor. And in addition, what you also need is to have smooth muscle cells that give structure to this stroma, and those are called periocytes, or smooth muscle cells, which give structure. And it turns out, and we're going to move along very quickly, that Diaz-Baran mentioned that when you have the periocytes, it gives you a greater stromal structure. That gives you the stromal 2 gene signature, which is seen in low-grade lymphomas, as opposed to the stromal 1 gene signature, which really brings in a lot of these cells, but doesn't give much structure to it. So a lot of angiogenesis goes on in the aggressive lymphomas, and not so much angiogenesis goes in the low-grade lymphomas. At least the angiogenesis which occurs gives you a greater structure and gives you the stromal 1 gene signature. Now, I want to move on very quickly to just show you a couple of things which I think maybe have helped to you. We talked about the mechanisms of the IMiDs in terms of their giving off, blocking angiogenic cytokines, which are given off once the tumor cell attaches to the stroma. The tumor cell gives off these various cytokines such as VEGF and basophilic fibroblastic growth factor and the such. So we do know that IMiDs play a role in angiogenesis, in inhibiting angiogenesis, and here is just a brief outline of IMiDs in non-Hodgkin's lymphoma and chronic lymphatic leukemia. Suffice it to say, it clearly, these 2 drugs, these 2 IMiD drugs that are available on the market, both thalidomide and lenalidomide, have great activity in the lymphomas. But one of the problems with Revlimid or lenalidomide is that it's marrow-toxic, and you heard various discussions here, particularly in CLL, where we only can give 5 milligrams, whereas thalidomide causes great somnolence and neuropathy, but doesn't cause much bone marrow toxicity. We've combined these 2 drugs, using them in alternating fashion in this thrill regimen, which you see listed down here. And what's very nice about the thrill regimen, which combines Rituxan with thalidomide alternating with lenalidomide, is that you don't get much toxicity because you're using half of each one of these drugs, and also these drugs have slightly different mechanisms of action. For instance, if you have some thal resistance, you can still show responses if you use lenalidomide. So what we have done is combine these and alternating these 2 drugs, so that if you're using these drugs in the clinic and you find that you're having difficulty with toxicity, if you go at an alternating regimen, which is a continuous regimen, you may find it very, very effective in various hematologic malignancies, particularly the lymphatic malignancies that are resistant. I'm going to move on very quickly to talk about metronomic chemotherapy. All metronomic chemotherapy is the continuous application of chemotherapy in low doses that are usually too low to cause the death of a tumor cell. What these low doses do is they attack the endothelial cell, or attack the angiogenesis, if you will. And we developed a program. Let me just go backtrack 1 second. One of the nice things of metronomic therapy is that you prevent what we call the outflowing of progenitor cells. If you look over here at the effects of CEP mobilization, when you give a high dose of chemotherapy, what you do is you kill the tumor, but what happens is as the chemotherapy effect wears off, you have a bolus effect in terms of the progenitor endothelial cells, which, as you can see, are located here on this. Let me go back. I guess, where's the pointer? Well, if you look over here, you'll see. If you look here, you'll see that with the high doses of chemotherapy, once the chemotherapy effect wears off, that these circulating endothelial progenitors come out and rush out into the system. As a result, you have angiogenesis really being recreated, whereas if you give continuous low-dose therapy and metronomic effects, thank you very much. If you give low-dose metronomic therapy, you do not get this rush of endothelial cells. A number of years ago, I got the bright idea, since I was sort of the court of last resort for many of these patients, to come up with a combination regimen that was very convenient for people who were end stage. So I thought I had the brilliant idea of using a combination of oral drugs that were effective in lymphoma. And I thought this was just a brilliant, wonderful idea. And what I did is I put together 4 drugs that are commonly on the market, which you can all get a hold of. I gave 20 milligrams of prednisone in the morning. I gave 50 milligrams of Cytoxan with lunch. I gave 50 milligrams of etoposide for dinner, and I gave 50 milligrams of procarbazine at bedtime. Now, I thought I was being very smart that I was using combination chemotherapy. But as it turns out, if you look at the half-life of any of these oral agents, they're really not very long. So what was happening is, instead of giving combination chemotherapy, what I was giving was a continuous dose of therapy throughout the entire day with different mechanisms of action. And here is this regimen, which we call the PEP-C regimen, which is prednisone, etoposide, procarbazine, and Cytoxan. We give the procarbazine at bedtime primarily because it causes some degree of nausea, and we usually give it with an antiemetic. We give these 4 drugs continuously until the counts drop. We wait for the counts to come back, and then we use this combination, which is a very simple combination, an alternate day strategy, or 5 out of 7 days. We don't vary these drugs that are given. We just vary the number of days in which it's given. And I would like to show you some of the results which we've accumulated over the years. And what's really remarkable, and I adduce that these results are better than any of the highfalutin agents that you've heard about, Velcade, thalidomide, Revlimid, all these expensive new agents coming down the pike for mantle cell lymphoma. Well, in this instance of giving PEP-C, we got an 84% response rate, of which 42% were complete remissions. And I want to point out that these were heavily pretreated patients. For follicular lymphoma, we got an 83% response rate, of which 46% were complete remissions. This is a remarkably easy regimen to give. However, even though these are low doses of chemotherapy, you do get a lot of marrow toxicity. Part of the reason, I think, for the marrow toxicity is you're giving continuous therapy. And what continuous therapy does is it overrides the MDR1 gene, which is very heavily expressed in stem cells. So what happens is, by giving this continuous chemotherapy, you do get marrow suppression. But if you alter your drugs, such as you give them every other day, or 3 out of 5 days, or 5 out of 7 days, you will find that it's very remarkably tolerated, and its activity across a broad range of various lymphomas, including T-cell, Hodgkin's disease, diffuse large B-cell, and marginal zone. However, let me caution you that this regimen does not work very well for very rapidly growing diseases, such as a Burkitt's lymphoma or a double-hit lymphoma. But for the average person who has no other place to go, this oral combination works very, very well. And let's see, well, I guess we're about at 5 minutes, so I'll stop right there, and we'll go ahead and take questions from the audience for any of the presentations. Thank you very much.